All right. Well, good afternoon, everybody, and thank you for coming. My name is Matthew Eisenberg, and I am the director of the Center for Mental Health and Addiction Policy. I'm pleased to have you all here with us today to talk about this important issue of suicide prevention in U.S. jails and prisons. The Center for Mental Health and Addiction Policy is devoted to trying to help people with mental health and addiction issues through policy research. We've been around for 10 years. This is our 10th year as a center. And this is, I'm good. This is our 10th year as a center. And we've been putting on this series of convenings in order to celebrate our 10 years together. This is the third event in our series. And we're excited for saving the one of the best for last. They were all the best, so I can't say one was. We want to take a moment to thank the University Provost's Office, the HBC staff, support from our hosting departments, the Department of Health Policy and Management and the Department of Mental Health, Sam Rosenberg, of course, and the HPM communications staff. So without further ado, I'll introduce those who took so much time in organizing this convening. Two of the faculty from the Center for Mental Health and Addiction Policy and Johns Hopkins, we have Oliva Sugarman and Paul Nestadt. So I'll invite them up to kick things off now. Thank you.
Good afternoon, everyone. Thank you again for joining us and to the Center for allowing us to host this event in this beautiful building. I've been here a couple times and it's just fantastic every time. I'm Oliva Sugarman. I'm an assistant scientist in the Department of Health Policy and Management. My colleague, Dr. Paul Nestadt, who you'll hear from shortly, and I co-led putting this event together. We both come from really different halves of the issue we're talking about today, corrections and suicide. My work focuses on overdose prevention policy, and a lot of that work is focused on incarceration. And Paul is the guy to talk to about suicide prevention. It's true. I'll start with some background on the corrections and health piece, and then I'll turn it over to Paul to talk about suicide and mental health. When we started planning this event, we expected there to be a ton of information about suicide prevention, policies, and best practices in correctional settings. But we learned many things throughout the process of planning this event. But the most prominent one is that despite almost 10 million people having some kind of contact with a correctional facility every year, there's alarmingly little recent information about corrections and suicide, about standards of practice to prevent or respond to suicides in correctional facilities, or policy to enforce those best practices. And I suspect that the people who know the most about this issue are about to talk to you and or are here or online. And then the second thing we learned is that we're in a really critical moment to create new, strong, and sustainable collaborations between corrections and health, which is why what we're talking about today is so important. Corrections plays a key role in mental health care. And for many people, corrections can be a crucial touch point to get connected to healthcare, to diagnose and treat a mental health illness on the path to preventing suicide during or after incarceration. So as you'll hear today, corrections, health, and legal experts alike recognize the importance of building the relationship between corrections and health. Policy is a crucial piece of fostering those relationships with the end goal of promoting health for incarcerated people and corrections staff, making safer, healthier communities, and saving lives. Before I hand it over to Paul, I want to take a moment to clarify some terms and concepts that will shape our conversation. There were some one-pagers on your seats. Those definitions and some others are on those handouts. I see often that the terms corrections, jails, and prisons are used interchangeably, but they have distinct functions and serve different populations and have different roles in the broader criminal legal system. Corrections or detention facilities cover a very wide range of facilities and people. In addition to jails and prisons, these can include facilities like juvenile detention centers, immigration detention, and a whole bunch of other kinds of facilities. Jails, in particular, are local facilities that typically house people who are either awaiting trial or serve short-term sentences, usually 1 year to 18 months or less. And for that reason, the population in jails can be in a state of flux almost constantly, with people coming and going quickly. And then prisons are state or federal institutions where people serve longer-term sentences, often longer than 18 months. People in prisons are generally incarcerated for extended periods of time, meaning that their needs are often more specific to chronic needs, whether it's longer-term medical care, rehabilitation, or reentry planning. What we'll talk mostly about today are jails and prisons. And with that, I will turn it to Paul.
Thanks. Thanks, Olivia. I just want to underline one of the things that Olivia said about how little we really know. I come from the suicide prevention world, not so much focused on jails and prisons and detention centers. And so when I started looking and playing this panel, I was amazed at how little data there was. The most recent rates we could find for suicides in jails and prisons were from 2019. This is just really amazing. So I wanted to thank you all for coming, because your being here really underscores the importance of this topic. Many of you traveled from far away to be here. Suicide is a growing public health crisis in general. Nationally, suicide rates have risen by over 35% over the past 20 years, such that now 50,000 Americans die by suicide each year. It's the highest rate we've had since World War II, the suicide rate in this country right now. About one person dies every 11 minutes in the US from suicide. There are certain populations that are affected more than others. We see high rates of suicide in indigenous populations. We see high rates of suicide in men and veterans. Lately, in the last few years, there's been an increase specifically in young people and the Black community of suicide. In prisons, we have a particularly vulnerable group to suicide, and that's why we're focusing on it today. Carceral suicide rates are alarmingly elevated. They continue to rise. In 2019, the most recent data I could find, the suicide rate in local jails was 49 per 100,000 per year. That's 3 or 4 times what we see in the general population, which hovers around 14 or 15 per 100,000 per year. And there's been an increase. Between 2015 and 2019 alone, the annual number of suicides increased by 85% in state prisons, by 61% in federal prisons, and by 13% in local jails, where the rates are the highest. Behind these numbers lie complicated realities. We know that there are specific vulnerable periods. We don't know enough about them, but we know that, for instance, many of these suicides happen early on in incarceration. In jails, most suicides, almost 1/3 of jail suicides occur in the first 7 days after incarceration. In prisons, around 30% of suicides occur in the first 1 to 5 years of incarceration. And the suicide risk doesn't diminish on release either. Among the 7.1 million US adults released from incarceration in 2019, nearly 20% of their suicides occurred very soon after their release. I think in the first year, I'll turn my page to remind myself, in the past year, with another 7% occurring in the second year after release. I do, though, want to dispel a dangerous myth that suicide or death in prison is inevitable. In fact, we see tremendous variation among different settings, among different prisons. Some prisons will have no suicides for years. Others will have multiple in a given year. That shows us that there are different policies that could be in place that could affect that suicide rate. We know there are things that we could do wrong, things that we can do right, and things that we can learn from what's been working. It's part of what we want to talk about in this panel today. Our ability to respond, though, remains constrained by insufficient data, as I mentioned before. Despite federal mandates, there's no consistent standardized approach to reporting suicides in correctional facilities, which limits our understanding of the full scope and the risk factors in this crisis. The research is alarmingly scarce. We have major gaps in some of the most basic things we need to know about jail and prison suicide in order to address them. Correctional facilities were never intended to be healthcare facilities. That wasn't what they were created for. But by default, due to systemic gaps, they've become frontline mental health facilities for millions of Americans. That puts them well positioned to be critical touch points for people that might not otherwise have access to mental health care or healthcare. So we have an opportunity to use what's happening in prisons as a way to actually help people that are incarcerated. The intersection of corrections and healthcare is crucial not only for reducing suicide rates, but also improving public health more broadly and safety broadly. State and federal policies are powerful tools that we could be using to impact suicide rates and healthcare through prison situations. So today's kind of a call to action. We brought experts together to bridge corrections, mental health care, strengthen policy, enhance training, and critically examine our practices to ensure comprehensive suicide prevention strategies. Effective suicide prevention and corrections is achievable. It's a moral, ethical, and legal imperative that's reflective of our values as a society. So I look forward to this panel discussion today. I'm confident that by confronting these realities openly and rigorously, we can forge a path towards safer, healthier communities for those incarcerated, but also for all of us as a society. So I want to thank you, and I want to introduce our moderator for this panel, Mr. Ryan Price. When Olivia and I started to ask around about who would be good for this panel, talking about panelists, but also who's got a good overview, so many people we spoke to said, well, you got to first talk to Ryan Price, who's done a lot of work in this field. I'll tell you, Ryan's a dedicated nonprofit professional with over 10 years of experience in voluntary health organizations. As Senior Director of Special Projects at the AFSP, American Foundation for Suicide Prevention's Program Operations Department, he spearheads suicide prevention initiatives across correctional systems, firearms, construction, and military and veteran communities. His passion for corrections-based suicide prevention developed after collaborating with the Oregon Department of Corrections to establish an innovative awareness and education program for adults in custody. Ryan also played a key role in developing the Talk Saves Lives Suicide Prevention and Corrections System, a module for staff, which was an impactful presentation designed to equip corrections personnel with essential suicide prevention interventions. This program also focuses on the well-being of corrections staff and encourages staff to seek help and utilize resources like the employee assistance programs to take care of their own mental health. All right, so I'd like to bring Ryan up.
I'll probably sit down eventually, but thank you all for taking the time to be here. For those of you that have tuned in online, thank you so much. So a couple of housekeeping things. For those of you that are in the room, those of you that are online as well, you have a QR code to Slido. You can just pull up your phone's camera app or go to slido.com and enter the code that you see on the screen. Ask your questions there. We're going to be reviewing the questions throughout our conversation this afternoon. I'll probably stop at some point and remind folks to do that as well. We'll have plenty of time for questions. So as you have questions, ask them through Slido, and we will answer them towards the end. So now I get to introduce our panelists for today, and I'll start one by one. I'll start with Dr. Joseph Penn. I'll ask him to come up and take a seat as I'm introducing him. Dr. Joseph Penn, you'll see, is a clinical professor in the Department of Psychiatry and Behavioral Sciences at UTMB Galveston, Texas. He also serves on the board as a board liaison for the American Academy of Psychiatry and the Law organization, of the AAPL. Is also the National Commission of Correctional Healthcare, past chair twice. So Dr. Penn, thanks for joining us. Next is Madeline Wasilchak. She is an assistant professor of law at the University of South Carolina, Joseph Rice School. And her work focuses on criminal legal system issues, including things like policing, race, conditions of confinement, and the prosecution and detention of children, among other things. She also directs the Youth Defender Clinic and teaches the Eighth Amendment law and litigation, criminal adjudication, and a juvenile justice seminar as well. Dr. Lauren Weinstock, now I'll ask to come up, is a clinical psychologist and professor of psychiatry and human behavior at Brown, where she conducts research on the development and evolution of adjunctive behavioral interventions for severe mood disorders like suicide prevention, especially during vulnerable transitions in care. Dr. Weinstock also serves as the MPI for the NIMH-funded group called the National Center for Health and Justice Integration for Suicide Prevention, or NCHAT. So if you don't mind giving a round of applause to our panelists today. So we are going to start with a couple of things. And throughout this discussion, we'll be framing this, again, around the public health perspective and trying to focus on policies as well. Things that we might be able to do or that are being done for that. Because as Dr. Nestadt said, this is a public health concern. And so we want to make sure that those that that die by suicide, that attempt suicide while incarcerated, anyone that's been involved in the system has access to care. So I want to dive in a little bit deeper to like a high-level overview of the correction system. So Madeline, could you provide that? We got a little bit, but it's a little more complicated, right?
Absolutely. So Olivia helped us out with the definitions of jails and prisons. As a review, jails usually are for those not yet convicted of any crime being held pre-trial. The average length of stay is really short. Many people come in and out of jail in a day, but because trial waits are very long, you could also spend 5 years, 10 years awaiting trial, and average trial time to trial is higher than it has been in a long time in the US, with a sort of lag from COVID and other system pressures. And then after conviction, one might serve a short sentence. In most states, up to a year, but depending on the state, 18 months, 2 years, shorter sentences in the criminal legal system. Of course, then if one were convicted and sent to prison, they could serve a long prison sentence in a state facility. And those range from minimum security facilities to maximum securities, facilities with work release, to facilities where people are locked in their cells most of the time, 23/7. After release, either from parole or from expiration of a sentence, one might re-enter as a parolee with conditions and might be under the supervision of a corrections department. This is also a really important time for suicide risk because re-entry is really challenging. We often think of freedom as a moment of joy and happiness, which it is, but there are real challenges that come with going home or trying to find a home to go home to. And if a conviction happens, but one is not sentenced to prison, one might be part of the community corrections program, something like a probation program. And millions of Americans are on probation. It's one of the larger footprints of our criminal legal system. And then there are juvenile detention facilities. There are pretrial detention facilities and also juvenile prisons where kids can serve usually up to their 21st or 22nd birthdays in custody in facilities that look exactly like adult prisons. And so these can vary from group homes that look more like communal living that might be arranged for foster care, all the way up to something that looks just like an adult prison, in which the conditions very much mirror those of adult prisons, with high rates of sexual abuse, high rates of children with mental health needs, and educational disabilities that require specialized care. And so that's kind of a quick look.
Yeah, thank you. And it's important to recognize just the complexity of the whole entire system. So, Dr. Penn, I want to ask you, we heard from Paul about, how the fact that corrections was never really intended to be a healthcare facility, but it is. And you have done time in prison, serving as a provider. So could you tell us about what healthcare inside a prison looks like or inside a jail? Like, give us an overview so we can understand.
Sure. So it's a challenge because Paul said it very nicely. I say this all the time. We were never designed to be healthcare facilities. So we have pregnant women. We have little men and women walking around with canes and crutches and walkers. We have people that are physically handicapped, blind, hearing impaired, you name it, transgender, gender dysphoria. So it's a heterogeneous. So that if y'all get anything from me, I would say the big takeaways are: one, it's a chronic population. So we have people with chronic medical disease, chronic mental illness, also known as serious mental illness. We become the state hospitals. We become the state mental health facilities because, and again, no disrespect to anybody, but unfortunately, a lot of people could have gotten healthcare, medical or mental health care in the free world, but they don't, and they end up getting it while they're incarcerated. So it's a heterogeneous population. I would say a lot of comorbidity. So it's not uncommon to have someone that has schizophrenia and hepatitis C, and they've had post-traumatic stress disorder from trauma or abuse or neglect, and, oh, by the way, maybe drug addiction. So comorbidity is the norm rather than the exception. And we really are seeing sicker and sicker patients. So I think those are probably the main themes: comorbidity, chronicity. And then I would say for jails, some of the challenges that they struggle with, it's like an emergency room. You never know what's going to come in the door. Some patients are truly acute. The question is, are they under the influence of something? Are they psychotic? Is it bad behavior, or is it all the above? And so it's really, is it mad or bad? And I think jails really struggle, and then they get to detox individuals. So fortunately in prison, we have the luxury, most patients have already been detoxed by the time they come to us in prison. So anyway, those are some important themes that I wanted to cover.
Yeah, thank you. And that highlights just how complicated this is, right? Because not only is there healthcare within the facilities, but there's also what happens when people get out. And this is where, some emerging research has started. So Dr. Weinstock, if you can tell us about some of the challenges of conducting research with the vulnerable populations of incarcerated, and And then also if you can frame it up for us about how this not only affects the populations of people that are currently incarcerated, but what happens when they get out and what have we learned recently?
So those are such great questions, and I feel like it would be hard to be succinct about it. And I think I would start with where we started today with Olivia and Paul's comments that we have so little research to guide our best practices, particularly with respect to suicide prevention, but certainly with respect to supporting people across these transitions. And my work began primarily focused on working to support people during transitions in care from inpatient psychiatric settings or from emergency departments. And this is how sometimes science develops, right? I was having regular lunches with a colleague of mine who was doing work in the jail, in the prison in Rhode Island. And we started to realize that so many of the issues that I was encountering in the research we were doing with people in the hospital were the exact same issues that she was encountering with people who are transitioning in and out of jails and prisons. And with one big difference, though, of course, is that the body of literature to support what I was doing was much bigger and very minimal with respect to what she was doing. And so that started a really strong and ongoing collaboration for us, really focused on this piece around reentry, because the risk is, as Paul mentioned, in jail, for example, is around like 4 times the general population. That increases to roughly 10 times the general population in the year after release from jail. So we kind of, when we think about a research question, you want to frame your question and think about where you can really maximize your impact. And we really focused on that particular period for our work. We really feel that we're still kind of lone rangers a bit with respect to this. And I think it's an area that I would really encourage people who are interested in research to focus on, because it is so important and we have so little science to guide how to best support people, and really thinking about how to help people from falling through cracks in our systems of care. It's very challenging to the question of conducting the research, because people who are leaving jails and prisons, their lives are very chaotic. They don't have a lot of supports. They are entering oftentimes unsafe environments, which increases risk. And so it can be challenging. I think that's why there are probably fewer people who do research in this area, because it requires a lot of manpower. It requires a lot of money. Very thankful to NIMH, for example, for supporting our center in this work. And Dr. Jane Pearson, I'll give a little shout out to her as a champion for this work at NIMH. So I don't know if that answers your question, but I think what we really need to focus on is not just what's happening inside jails and prisons, but also what's happening after incarceration, but also, as we're learning from our research as well, a lot of times people are finding themselves in jail, particularly on the tail end of a crisis. So it's not just what happens inside and after, but it's also what's happening right before somebody comes into contact with law enforcement. And again, that concept of a touch point is really important. We're finding people who have very high needs, are at very high risk, and they're moving through these complex fractured systems. And that's where we really want to try to support them. And we're trying to understand that better through research.
Yeah, so we kind of know enough about suicide risk to know that most people involved in the criminal legal system have a bunch of risk factors for suicide, right? One thing that's interesting in carceral settings for those that are incarcerated, everything is controlled from meal times to where people can go, what they can wear. And Dr. Penn, that's true, right? For best practices for healthcare and things like that related to suicide, right? I'm being sarcastic, but.
Well, I think that's a great point. I was going to dovetail on what she brought up earlier, that it'd be in a perfect world, academia could really bring stuff to the table and do research, but a lot of systems are kind of paranoid or suspicious because they're like, whoa, wait a minute, what are you going to do with this research? And if you publish something and it has a negative finding, or something that the legislature or the leadership gets concerned about, there's always litigation and lawsuits, and we can talk about that if there's time. But I think there are best practices in corrections, and I think the issue is it's a very militaristic, there's hierarchy, there's rank, whether you're talking about in a prison, you have wardens, deputy wardens, captains, majors, same thing in a sheriff, same thing, deputy, different ranks. And there are policies and procedures and there are best practices, and there's typically each state or county has their own rules or regulations that they have to follow, jail commission standards or national standards. But I think the challenge is infusing the academia best practices and national standards into the day-to-day work and avoiding lawsuits and litigation. And I was just going to add the other public health issue that I don't think it's talked about much is what about the families of people that have a suicide? And two, what about the healthcare staff or the custody staff that are rescuing them, cutting them down, or they're exsanguinating? What kind of trauma can that cause to those staff that they're trying to help them and rescue them and they find someone? So it's a double, triple, quadruple whammy to all involved.
Yeah, what about the practices specifically related to acute suicide risk, those that have said that they're thinking of suicide? What are there best practices for that? How have they been adopted, and what can we do from a policy perspective to maybe ensure that those lives are at have the greatest potential to be saved in those moments?
So I'm really curious to hear from my attorney colleague, legal colleague here. One of the challenges in corrections is everything is kind of black and white. If you tell someone 5-minute checks or 15-minute checks, they're going to do that. And what we found in NCCHC, the National Commission on Correctional Healthcare, is making suicide watch unpredictable and making it humane, because stripping somebody naked and putting them in a cell, that's not the answer. They're suicide resistant garment. And notice I use the word resistant, because people can still shred even a suicide proof garment that's a real thick quilted sort of garment. They still can shred that and use that as a ligature item like a noose and use it for a tie-up point. So we have to borrow things from Joint Commission, which has things about best practices. But I would say ACA, the American Correctional Association, NCCHC, have really good standards that help guide both custody staff and healthcare staff and administrators.
Yeah, I think when you mention the suicide resistant garment, I think of being a brand new public defender and being sent to visit someone who had been put in suicide watch, and I was supposed to take their initial interview. And I was 24, 25. And this person was a young man, also probably around my same age. And he was in what looked like a fishbowl, all glass, or probably not glass, but clear, translucent, and wearing this blanket. And he's supposed to now talk to his legal counsel about what's going on. I think one of the things that people who have spent time in custody say about suicide watch is, of course, you don't go on suicide watch. Of course, you don't admit to being suicidal or having suicidal ideation, because you know what happens to you. If you've been anywhere near that system, you know what happens to you. And so making suicide watch so punitive, making mental health treatment so punitive, is really counterproductive, because people are not going to self-identify as having those thoughts in that setting. On top of that, we then contract for release a lot of the time. So you tell someone, in order to get out, you have to sign this document that says that you're no longer suicidal and you aren't going to commit suicide, which is no assurance that anyone is not going to commit suicide or that their circumstances have changed or that their mindset has changed. But you have given them a whole lot of motivation to sign that document, because they're in a cell. Many suicide watch cells, the one I saw in Philadelphia was thankfully clean, but many are not. The book by Michael Walker, called Doing Indefinite, Doing Time in Jail, has a scene at the beginning where he spends time in a suicide watch cell that he calls the Palace de Excreta, because there is human excrement smeared all over the walls, and you don't have a place to sit, and you don't have a comfortable bed, and you don't have a mattress and you don't have real clothing. And so, of course, you want to sign that, regardless of the truth of the situation. And then for all of the hope that people are doing their 5-minute, 10-minute, however many regimented checks, I find that in many of the suicides that I've reviewed in collecting my deaths in custody database for South Carolina, they aren't being done. And I think this goes to a combination of things. This goes to staffing. This goes to thinking this is important. And also you can watch how people do those checks. Is there a stop and a look inside to see what's actually happening, or do we pass down the hall without really paying attention and making sure someone is really okay? And there are many suicide deaths that I've reviewed for South Carolina where the person just wasn't checked on, and it was known that they were in an acute situation, and we waited too long, and it was too late. So I think bringing some dignity to the situation and also bringing policy, best practices that go beyond the minimum constitutional standards, because what the Constitution requires isn't always enough to keep people safe.
I would just, I mean, I agree with everything the other panelists have said. I would just add that the sphere of litigation and liability, on the one hand, there are issues with staffing and other things where maybe people aren't doing what they're supposed to do. But then on the other hand, it's the opposite. There's sort of an overcorrection where people kind of have this knee-jerk reaction. And we see this in healthcare too, quite frankly, where people hear the word suicide and they get very anxious and they kind of take these very extreme stances. And I can think of an anecdote of somebody we worked with in one of our clinical trials who had been arrested and detained in jail on a Friday night, and they were not suicidal. They denied any of the screening questions when they first were assessed, and they did have a history of psychiatric hospitalization, which was not even that recent to this event. But because it was a Friday night and because they were going into the weekend, what the jail had decided to do was put this person in segregation on suicide watch. And when we finally met with them after the fact, they said, I wasn't suicidal when I arrived, but I became suicidal being in that segregation cell all weekend. And so I think what's really important and what we, hopefully, and again, I approach this from a research perspective, if we can present the data to support systems change, it's a lot of education that is important, in addition to, we'll get to this, I think, later too, just policy change that needs to happen, because what is best practice and what is happening, I think, are often disconnected.
I just want to make one quick comment. I know corrections, nobody wants their loved one behind bars. I get that. But I will say, fortunately, in my opinion, it's just a minority, a small number of people that don't follow policy and procedure. For the most part, I'll share a state of Texas. We have close to 140,000 people incarcerated a day. We're not having 140,000 suicides. So it's a relatively rare phenomenon when it does happen. What I would say is too, the other thing that I really think that we're advantaged of in corrections is we can have a psychiatrist see someone same day or the next day. Can y'all do that in the free world? No, it's a 6-month to a year wait to get in to see a psychiatrist. So we have qualified mental health professionals, masters, doctoral level staff that go cell side. They see people in really very oppressive, not fun places to work, and they go and they do this work. So we have committed healthcare staff, custody staff, medical staff that do a great job. Yes, we have some that don't follow policy and procedures. They probably get disciplined or terminated, and they probably end up disciplined, if they don't do policy or procedure, they get fired. But what I would say is the majority of staff that I interface with, I can speak for Texas, is they're hardworking individuals that are trying to do the right thing.
Yeah, then that's a good point, because what we do know from the data, and I'll transition to data too. We can talk about the challenges of data collection next. But a first reminder, Slido for questions. You can use the QR code on the screen, enter that little number that you see that starts with 19 after. But that we do know that suicide is the leading cause of preventable death in prisons and the leading cause of death in jails. But as a function of the population, it's still a fairly small amount of suicides. But to your point, where there are gaps, we need to try and identify them and improve the outcomes and get better at providing care, humanizing the experience for people that are in that situation. But there are some challenges with data collection. We alluded to it earlier, but can we talk about the fact that, what the same situation in one state might be reported differently in another?
Sure. So I, along with colleagues in the Carceral Deaths Data Collective, we have a group started by Andrea Armstrong in Louisiana. We have projects at UCLA, 2 projects in Texas, in Georgia. I'm surely missing people, but I can link you to those if they're interested. Most of us have to public records request our data. The BJS, so the 2019 data that was referred to was from the Bureau of Justice Statistics that was collected under DCRA, the Deaths in Custody Reporting Act. And when the Deaths in Custody Reporting Act was reauthorized, there became a stick attached to the reporting. So if you didn't report, certain amounts of federal funding could be withheld, which has never actually happened, to be clear. But because of that, the Bureau of Justice Statistics can no longer administer the program because they can't do any law enforcement. So collection went to the Bureau of Justice Administration, which is not a statistics agency and is not generally, that is not what they are oriented toward. They're primarily grant making organization or administration. So the data collection went to a different tool that has less information and became a lot spottier. And because of that, BJA has not been releasing that data because it just isn't very reliable. Each state has an organ or has some organ of the state that reports that data to BJA. In South Carolina, for example, it's the Department of Public Safety. In some states, it's the Departments of Correction. It could vary. And many states, though not all, also have a mechanism for deaths in custody reporting at a state level. For us in South Carolina, all the jails are supposed to fill out an SCDC 82 form, which goes to the Department of Corrections and is usually handwritten by the correctional officer who discovers the death and then sends it to them, to the Department of Corrections. And so there are so many different mechanisms. They often collect different kinds of data. So an important issue that Dr. Weinstock brought up is that a lot of suicide deaths happen in segregation, in SHUs, in the hole, in whatever you want to call solitary confinement. And we know that, but you can't always tell, depending on how data is reported, where someone died. And the data may report where they died, which is the hospital, when in fact the occurrence that caused the death, the suicide attempt, happened in segregation or somewhere else. And those kinds of small details are really important for understanding what the right intervention is, but we often don't have that fine-grained data. So that's what our project is trying to step in the gap for.
Well, and if you heard it, you just named off a handful of states, right? So the larger volume of states probably doesn't have a strong practice like that.
Right. So UCLA's project is gathering prison data from every state to the extent that they can, but jails are much more of a black hole. They're at the local level, so you generally are having to get information at the county level, which is much more difficult and much more time consuming. We're lucky in South Carolina, we have 46 counties. Texas has, I think, 146, 200 and some change. Okay, so that's a lot more different places to try to chase down. And yeah, we just don't have that knowledge. And then beyond that, juvenile detention, ICE facilities, immigration detention, other places, we do not have eyes in those spaces yet.
And that's just inside the system. Can we talk about a little bit more about what happens when you get out, and also the transition for continuity of care? Because someone might go into a prison or a jail and then get on treatment, seeing a psychiatrist, getting on medication to manage a mental health condition. What happens when they get out?
In terms of the data collection or in
In
terms
terms
the
of their care
experience?
and the data
Oh,
collection, yeah.
It's very fractured, right? So, there's this expectation that reentry planning is happening, but because of a variety, every system is very overburdened. They don't have resources. More recently, I feel that it's gotten worse in terms of funding and supports. And so people, when they're still incarcerated, they're not having the reentry planning that those of us on the outside would expect there to be happening. And even when there is reentry planning, then you're also working to try to bridge someone's care into systems that are also completely overburdened and not able to support the mental health and substance treatment needs of our communities widespread. I mean, we are all aware of how overburdened and taxed our mental health care systems are in the United States. And so you have sort of this compounded issue, right? So if somebody can connect to care, that's wonderful. I'd say that at least in my experience, that's happening more and more infrequently because of these systems that have just broken down around people. There have been, and this is an area I know a little bit less about, so some of the other panelists could speak to these Medicaid waivers and extensions that I think are promising and helping to bridge that gap. But I think it probably isn't enough because we're just really struggling to support the needs of our population generally. And then when we think about people who have these specific needs around transitions in care from incarceration or correctional settings back to the community, generally speaking, they're already coming from a context of impoverishment and lack of resources. And so placing them into a system where it's already overburdened, it's just very challenging, I would say.
I totally agree. I would say for jails, it's even more difficult because to the point made earlier, you could be in a jail overnight, a few hours, right? You could be there weeks, months, years, depending on how serious the crime is that you're alleged to have committed. But when they release you at a court hearing or you post bail, it's like, see ya, and you leave. And you're probably not getting discharge medications. Some jails do better with that, some don't. I'm proud to report in Texas, we give a 30-day supply, 30 days. But get this, even with a 30-day supply, whether it be a juvenile or an adult, guess how often we get called, hey doc, can you do a refill because we can't get this person in? So we used to do a 2-week supply because we were trying to push the outside agencies to step up and that handoff piece, but you really need patient navigators. And I'll brag on our system in Texas. We have TACOME, the Texas Correctional Office for Offenders with Medical or Mental Impairments. It's a mouthful, say that 5 times fast. But TACOME, they help people get identification cards, get their Medicaid reinstated, help them find out appointments, and actually maybe even go meet with them while they're still incarcerated before they leave, as opposed to just giving them, here's a card, call this number. And I think the biggest challenges are affordable housing, substance abuse treatment programs. Some systems have MAT, medication assisted therapy, or MOUD. Some systems don't have that. So you really got to figure out that handoff, both from a medical, mental health, and substance perspective, and getting them tied into the resources. It's one thing if they're in a big city, but if they're in rural Texas, good luck with that. So I think that even Rhode Island, I lived there 15 years, Rhode Island has Providence, Warwick, and other, big cities. But if you're out in the burbs or in underserved areas, even a small state like Rhode Island, it can be a challenge.
And I think that's a big part of both the inside and outside treatment is that our substance use, behavioral health, mental health service providers tend to be located in cities. Our prisons and many jails are located not in cities. And at this point, our suburban and rural populations have higher per capita incarceration rates. Cities actually are not the leading incarcerators anymore. And so we are moving people into healthcare deserts. and releasing them into healthcare deserts.
So from this policy perspective, I mean, what can we do? Because it sounds like there's some pockets of things being done. There's some research in Michigan, maybe some work in South Carolina and a few other states. Texas seems like it's got a handle on things. But what do we do? How do we take those best practices that have shown promise in places and then scale them up across the country?
Well, I'll kick it off. I'll just say, first of all, you need to have healthcare standards because everyone that comes in right now, y'all remember COVID, right? Well, now we're dealing with measles. Measles is blowing up in West Texas. It's just a matter of time before it gets across everywhere else. So infectious diseases, we have tuberculosis. We have, I see Dr. Johnny Wu in the crowd. We have TB resistant strain. So we have a lot of infectious diseases. Think of it like a big cruise ship. So there's a risk of infectious disease. So I think the big thing is figuring out healthcare standards, whether they be ACA, American Correctional Association, NCCHC. Of course, I'm biased, but I think that they have designated healthcare standards for jails, prisons, juvenile facilities, opioid treatment facilities, mental health standards, ncchc.org. Great resource. They put on conferences, they train staff. So I think you want a good workforce that know national standards, whether they be ACA or NCCHC. So I would say from a healthcare perspective, that's low-hanging fruit. The next step is, I'll let y'all talk about Medicaid and eligibility and the handoff piece and patient advocate, because to me, that's the next step.
I'm not that qualified to talk about Medicaid, though I think the that bridge is really, really important. What I would say from sort of the legal perspective is I think we have to stop regulating our carceral system through litigation and start actually regulating it through laws and oversight. Those standards are great. We have minimum standards in South Carolina, but we don't really have an oversight mechanism. The only lever that our State Department of Corrections has to pull is to close a facility. And that's not a realistic solution. And so the question is, if there is no consequence to falling below minimum standards, other than maybe the possibility of litigation, which is time consuming and not really an effective way to regulate, then what? And so I think we need to think about, what does independent oversight look like? There are other countries that have good ombudsman programs or good oversight programs that exist outside of corrections and don't require litigation. There's also legislation that could be put in place that institutes particular remedies if facilities fall below minimum standards. And I think thinking about doing something other than regulation through litigation, even though it is really important that all of the people behind bars do have a right to healthcare, that right isn't enough to keep them safe.
Yeah, thank you. This is such a good conversation, and I want to just transition us into some audience questions. We've got some really good ones that have come in already, so still plenty of time to get your questions in. I'll start with this one. What needs to be done to mount and fund a psychological autopsy study of the suicides in correctional settings with a focus on behavioral signs of acute risk in the last days of life? Is it money?
I mean, well, money is always the answer to a lot of our questions, right? And this is very hard work, and it requires a lot of people power and a lot of money, I would say, to really support an infrastructure to do that work. I'm stammering because it's so overwhelming to think about what a psychological autopsy study would look like, given that it's not even clear to us, as we were discussing earlier, that we're able to identify all of the suicide deaths that are happening in custody to begin with. So then to identify who's dying by suicide and then doing a true psychological autopsy is a very challenging task, because you're starting from a place where you may not even be identifying all of the deaths. I will say, to this point a little bit, the National Violent Death Reporting System has in its restricted database some information about the setting of death when a suicide has been identified and reported into the NVDRS. So there are some data that identify people who have died by suicide in custody through that particular data set for people who are interested in exploring those questions. It doesn't really allow you to do psychological autopsy, but possibly working with your state Department of Health, the local state VDRS, who's working to kind of identify and process, in Rhode Island, for example, we have some efforts that are ongoing around creating suicide review committees. So you could partner, and actually, sorry, I'm babbling, but I think one of the biggest things I've learned from doing this work, we talk about this in lots of behavioral health research, is the importance of community engaged principles. And I actually think that's where this really comes into play, because all of this work from a research perspective really requires you to be embedded and working side by side with all of the partners here. One, because you're not going to get very far if you're not, but also the trust building is very important to the point where people are very skeptical of researchers and what you're going to uncover or find and what your motivations are in research, but also people are very busy. They have other things that are more important to them. They're not particularly invested in research the way we are as researchers. And so working side by side and helping people see that you're a value add and not someone who's going to come in and burden the system is really important. And developing those relationships and sustaining them over time is going to allow you to form a partnership that can last a long time, so that you can get to a point where maybe this type of psychological autopsy study could be done.
Could I piggyback? I think, first of all, I agree everything she said. I think psychological autopsy is a very nebulous issue in corrections. I'd be curious, Paul, if you have thoughts on this, but we're looking at some of the how to standardize that. And I guess where I stand, it's not so much the document, because documents are check the boxes and gets filed away, but it's more the process, or if you're in Canada, process. How do you actually go through as a multidisciplinary team, custody, nursing, medical, dental, mental health care, ombudsman, legal, everyone sitting at the table and talking without finger pointing, without blaming, oh, custody screwed this one up or mental health screwed this one up. That's of no use. But how do you do like a critical incident review, morbidity mortality review, a serious incident review? How do you do this in a multidisciplinary fashion, come up with recommendations, who's going to be responsible for what, as opposed to just filling out a form that gets filed away and nobody ever sees it? So I think that's kind of what needs to happen. And we need to have more standardization. I think there needs to be something about, when there's a definition for psychological autopsy, but who should do it and in what time frame, and who's the qualified person to do it. I think standardization would be useful.
And I guess I would just add to that transparency to families. I think families too often are locked out of information about how their loved one died. It can be really difficult to get that information. So I think insofar as something like that is created, building a place for family to participate and to understand what happened in the final moments of their loved ones' lives.
Yeah, thank you. And this leads into the next question. As you were talking about, Dr. Penn, the standards and how we can do this in the right way. But we do know, it's a great question, that understaffing is an issue. And so is there any relationship or any research that shows or looks at the relationship between staffing and the risk of suicide? And then a secondary question, does having a robust mental health clinical staff at a reasonable ratio decrease the risk of suicide?
So I would say a couple of things. So one, families can be very helpful. Like if they sense a change in their loved one, nowadays some systems have tablets. There's ways our loved ones can communicate, via internet or via text messaging and what have you, or during physical visits. We know during COVID, physical visits kind of came to a grinding halt, and a lot of these prisons are in the middle of nowhere. So it's really hard for families to go visit their loved one. But anyways, anything that the family member notices, and a lot of times that's what we respond to when they say, hey, my loved one's kind of not doing as well, or they're acting strange, or they're giving away their stuff. Other inmates were doing education, peer-to-peer wall talk and that sort of thing, faith-based ministry. So there's a lot can be done. It's not just custody and mental health care. But I think the biggest thing I would say is the standards can be helpful, but we use technology. And I think so. One of the questions is, it's not just going and checking off the boxes. Some systems have automated where you have to go and like use a metal or magnetic wand, and you can't fudge the data. Like after, let's say there's a suicide and then someone just goes in and says, yeah, and checked off the boxes after the fact. There's some where you have to walk from point A to point B and wand and stand there for a certain period of time. So it's tricky. I think, again, visualizing some inmates when they're incarcerated, if they're lined up against the cell door and you can't see through the cell door because it's all scratched up, those are some challenges. So I think the physical plant issues, what I would say is using technology, training up staff, and then also it's not just, like I said, custody and healthcare. It can also be volunteers that come into the facilities and provide group therapy or do other things. Um, those can be your eyes and ears that can help also. I don't know if that answers the
Yeah, so
question.
the way I think what I hear you saying is there may be some ways to acknowledge that staffing is a concern,
Yes.
to maybe support that growth and retention of solid staff, but also that there may be some mechanisms by which we can train up peers, volunteers, and others to notice when someone might be at risk and then report it up so that person can get the help that they need. So, but the question is, are we aware of any research that sort of has that link between understaffing and suicide?
We're working on it.
Okay. So not yet, maybe. Yeah.
Well, and what I was going to add is, unfortunately, a lot of the workforce, we used to have workforce where people like their uncle or their grandpa, or, everyone worked in generational in corrections. But and again, I'm not endorsing these companies, but with Amazon and these companies, why would you, or Buc-ee's in Texas, why would you want to go work in a prison when you can go work in an air-conditioned building and not have body fluids thrown at you, a more fun place to work. The other thing is, I mean, I think I mentioned it early, heterogeneous. We have some dangerous individuals behind bars. We have gang members that are very aggressive and assaultive. So we have to think about physical safety for our staff. I think in Texas, they've really tried to up the salaries, both for custody staff and for healthcare staff. And I think the thing we're fortunate is we're state employment, so we're University of Texas. But without state benefits and without loan repayment, it's really hard to get people to work behind bars. So those are some incentives that you can dangle at people. But I'll just say psychiatrists can make a lot more money in the free world compared to what we pay. So we're disadvantaged, I think, at the start.
Thank you. This question is one of my favorites because when at AFSP, when we created a program for incarcerated populations, it focused on the staff in those facilities. And so this question is, what are some protective measures, if any, that can be in place for correctional healthcare staff? And how do we care for the workforce? So maybe correctional healthcare staff, but also those in security, which are charged with keeping their colleagues and other people that live there safe.
Sounds like you're the one who has the answer to this question.
I'll give you something, but there's limited data on this as well. And there's a few small studies that show that corrections officers are at a fairly high risk of suicide. Most of them won't tell any colleagues about their suicide risk. And so a lot of states, maybe Texas is one. I do know South Carolina is one because we worked with the DOC on a program that are working to increase the availability, the usage and the robustness of offerings for staff, things like employee assistance programs, peer-to-peer support, and things like that. And so there are definitely things that we can, because as you just mentioned, it's not a great place to work all the time.
Can I tell a story?
Please.
It has nothing to do with suicide prevention, but a colleague of mine at Brown is really interested in yoga as an intervention for depression and other mental health conditions. And we've collaborated, and we had this idea, where you start off with an idea and then you think about how do you actually implement the idea, which was to conduct a small pilot trial of yoga as an intervention to help people in prison with their anger dysregulation, and with the idea that if we could improve people's experiences with anger as negative affect, that might improve their well-being. And we got the funding from NCCIH, and we were all excited and getting ready to start. And then we started to hit all these roadblocks along the way. And people said, even though we had letters of support and all the things that you want to do before you start your research, people said, you're not going to get buy-in from the COs. And if you don't have buy-in from the COs, it's going to be very hard to conduct these yoga classes in prison, because they're going to make it hard for you or something like that.
And COs meaning correctional
Corrections
officers.
yes,
So these are the people
exactly.
that are working in shifts
Right.
on unit floors,
Boots on the
directly
ground.
supervising.
Yeah. So even if we had all the permissions in the world to go in, if the COs aren't buying into what we're doing, it's going to be hard to do the work. And as it turns out, we ran a focus group. We invited people in. There is a CO in the system already leading yoga classes for other COs, and they love it. And they were very on board with what we were doing because they were taking care of themselves in this case. They had decided we need to do something to improve our own well-being. And there, this one particular CO just was really invested in yoga. She was a certified yoga teacher. And it was just a great lesson for us in how, if you take care of the people who are also responsible for caring for others, that can really just be a complete culture shift in the setting. And that trial was actually the smoothest run trial I've ever run in jails, prisons, or in hospital settings. And it was because we had so much buy-in. And it was, again, a great lesson in the need to take care of the staff on the inside as well as the people who are incarcerated.
I'm so glad you brought that up. We're not talking about hug a thug at all. That's not what we're talking. That point, it's a wellness. And I want to brag on our Texas juvenile system. They've embraced TBRI, trust-based relational interventions, but and the adult system is slowly getting there, but it's all about trauma. Our incarcerated individuals have had traumas in their life. They've had traumas while they're incarcerated, and our staff too. And so music therapy, my son's a professional musician, so I'm all about music. So music, occupational therapy, any kind of therapies, religious stuff. We have a lot of ministry behind bars, faith-based initiatives, but I think the yoga, physical activity, I think I go to a lot of prisons, and if you're just sitting in your cell all day, you're just going to gain a lot of weight and not do anything. Wellness, getting exercise, getting out, getting some sun, exposure, all that's really helpful. So I totally agree with you.
I think it's also important to remember that a lot of the people who are working in facilities come from a lot of the same communities of people that are incarcerated in those facilities. And that's not always true depending on the location. But that means they also come from not particularly high income backgrounds. They also have experienced trauma. They also maybe come from neighborhoods with violence. And then they're also in a setting where those things are happening, they're intervening in them, they're observing them. And then I think systems where things work well, those staff feel supported by their administration, their higher ups, and they feel comfortable reporting things. I think some of the reporting out of California about some of the violence and suicide rate, violence among incarcerated people, but then suicide rates in those same facilities among correctional officers goes to show that when people don't feel supported by their administration, when they feel like internal affairs or other things are not acting as they should, like those become real challenges. And so I think there's also like a workplace culture issue that can be addressed sometimes in places where things appear to be maybe not going as well.
Yeah, that's a great, that's great. Thank you. So we have two questions about litigation or lawsuit risks. If we can talk a little bit about them, are good questions though. So the first one is like, can we talk about any litigation sort of risks concerning the publication of suicide research in jails or prisons? And also, how or has litigation been used as a tool to improve mental health care in carceral settings? So let's start with the research question first. When conducting research in these settings, are we worried about litigation?
Maybe this is naive, but I'm not worried about litigation. I think we are very careful in the work we do, and we are reporting data in aggregate. So, we're very sensitive to people's privacy. We follow all of our protocols. We have a lot of regulatory involvement from our IRB. We have and I've worked with the NIMH Data Safety and Monitoring Board. Now I'm on it, actually, as a result of that experience. I think the concern is that the systems we partner with are afraid of what we might find, and that somehow will place them at risk. And we've worked very hard with those partners to help them understand that what we're trying to do is inform best practices. We're not trying to blow the lid off of something to get anyone in trouble. We're trying to understand what people's needs are and how can we best support and help them and what are the best ways to implement those. And we, in my work, we do that through research and through, the co-panelists here do that through other methods as well. But I wouldn't let that deter anyone who's interested in conducting research on questions related to this. I honestly go to sleep at night very soundly, feeling that we do a good job, and it's really about helping our partners understand that we're not there to expose them. We're there to help identify what the needs are and how to support people.
Yeah, and it is. If you're not familiar with this, I don't know how much, if we want to talk at all about this, but there was some not so great things that happened with research in prisons where experimental drugs and experimental interventions for all sorts of things. So now those that are incarcerated it's a vulnerable population. And so with that, there are very strict procedures that need to be followed and strict guidelines for that. So I don't know, is there anything else we would add to that?
I mean, the data I work with is public record. So, I mean, that's the other thing about these deaths in these facilities is I might not be able to get all the information I want about them, but the information that I can get is public record. And so we do republish it. I have a database. You can go look at the documents that I'm looking at. But that's because they're public records. So I feel very comfortable about the side of the law I'm on there.
I'm going to take a different side on this. So, I mean, I'm all for research, and I've done research behind bars, and it's not easy because you have to get an IRB. You also have to get not just your institutional from your university or med school, but also a prison IRB. So that could take 6 months to a year. Just good luck with that. Prisons and jails tend to be very leery and skeptical of outsiders. They don't know who you are or what you're doing. So it's all about developing a partnership. It could take years to cultivate that partnership. And that partnership, if you publish something, come to a grinding, screeching halt. So what I'm going to say is I think one of the challenges, I'm all for research, but when we do peer reviews, we write up stuff. Unfortunately, by there's state laws or statutes that say this is protected because it's under peer review and it's protected. In federal court, that's out the window, and you can explain that better. But so anything that we write, when we write up a case, it could be potentially discoverable. And I think I've seen some kicks and starts where certain states want to talk to each other. Hey, what's your policy on this? How are you doing this? What's your best practice on that? And it's something they're working on. NIC, National Institutes of Corrections, is doing that with all the state prisons in the country, and I think 3 or 4 of the largest county jails. But still, there's that reluctance to share information across state lines for fear of litigation and discoverability of stuff. So I don't know if you want to say something about that.
That is outside of my area of expertise.
I mean, I will just add, though, when you're conducting research that's funded by NIH, we have certificates of confidentiality. I've been fortunate to have funding from the National Institute of Justice. They have something called a privacy certificate, which is even more ironclad than an NIH certificate of confidentiality. So the data we're collecting, if that's the question, is pretty ironclad protected. What we've managed, though, is when people actually who are enrolled in our trials approach us and ask us to share their data as part of their ongoing litigation, because they want to show the judge, look what I'm doing. I'm working on and bettering myself. I'm working on this, I'm contributing to science. And so we have to also be really clear about expectations with data sharing, not so much because people are asking us to share their data, but the participants themselves want to release the data.
I think the biggest challenge is there's a finite amount of workspace, like clinic space, to do the work that we have to do. And if you have some research people that want to come in and do more work and do a 3-hour battery or do some fancy, evidence-based gold standard study, that's great and all. But in a jail or prison, it's hard to get people to do that. And it kind of bogs up the clinic, like the clinics are set clinic times. And so again, it's a partnership. It's how do you do this without overtaxing the existing, getting custody staff to bring up inmates, watching them, keeping staff safe. Those are some of the, the operational challenges that happen when you want to do research.
I mean, just practically speaking, I think as researchers, we always have all these ideas about what we want to include in our studies, and it's often more burdensome for the participants than, and conducting work in this setting, you have to really pare down what you're doing because it needs to be feasible. Absolutely. You can't go in with this idea that you're going to do the full, I mean, I've never done a full skid. I mean, some people do, but you really have to think, and in some ways it helps the science because it really helps focus your question. What are the most important things that I need to be asking participants in my study to answer the questions that we're trying to answer through science? And everything else just has to be put aside, quite frankly, because you don't have the time and you want to be a good partner and you don't want to complicate the various systems. For example, even when we go in, I run mostly clinical trials, and there are various points throughout the day where they do an inmate count. So we have to work around the inmate count. So we send research assistants in the morning, and they know at a certain time of day, they got to get out of there because there's other things happening in the system that we cannot complicate. And then they've got to wait a couple hours, and then they go back in to finish what they started. And so it really is about, the partnership is so critical for the research.
Thank you. So we've got a couple of minutes left before I want to wrap up the conversation. A few more questions. There's been a few good questions about sort of standards. And one question, is it a barrier or is it a challenge that states kind of set their own standards with a lot of these things? And also, if we can talk a little bit about some of the accrediting bodies that exist. I know, Dr. Penn, you won't do this. It's not an endorsement, but the National Commission on Correctional Healthcare is one sort of accrediting body, optional for facilities to do. There's also the American Correctional Association and Jail Association. And so can we talk about those standards and how and what are the ways that we can make it more accessible for states to get states on board with similar practices? Can we pull some policy levers in that way?
I mean, I think the Texas at the University of Texas, the School of Public Policy has a website called that I believe is prisonoversight.org. Certainly, if you look up Texas Public Policy Prison Oversight, you'll get there. And they are compiling standards and creating some best practice standards and also suggestions about oversight bodies and things. So I think they're doing really great work on that. The reality is I think 31 states have minimum standards, but that means there's a chunk of them that do not at all. And then the question is, do the standards get implemented? And I think that's where their piece on oversight also comes in. And so I think putting those tools out there, I know there's also now a tool, and I'm going to blank on who created it, but they about what should go in a jail medical contract, which I think is really important. We haven't really talked about non-state healthcare providers, but most jails don't have in-house healthcare providers. The majority of jails in the US hold fewer than 25 people. So they have contracts with medical providers that may be part-time, maybe doctors, maybe nurses, maybe include mental health staff, some do not. And so I think that template for what needs to be in there to provide adequate services is also a really important and helpful guidance.
Totally agree. I was going to add, I mean, at the end of the day, it's about money. And legislature folks, they don't get elected when they say, my campaign, I'm going to run on prison healthcare. That's my number one. You know, people, that doesn't get you elected. So it's kind of an afterthought, prison healthcare. We've been through 2 or 3 reductions in force where the legislature came in and said, you have to cut your budget by 10%. So recreational therapists, art therapists, music therapists, occupational therapists, whacked. Fortunately, oil and gas has done very, very good in Texas, so we're in good shape right now, knock on wood. But so you need steady, dedicated funding for your staff, both for custody and for healthcare staff. What I was going to say back to the standards, though, if you don't have staff, you can't get standard. You really got to have healthcare staff and qualified healthcare staff. There's this kind of myth that anybody can work behind bars, even if they have licensure issues. I would say most systems have really upped their game. And you have to be fully licensed, fully qualified, and you can't be under a medical or nursing board oversight. You have to have a clean license, if you will. And for sure, that's how we do it in our prison system in Texas and on the juvenile side too. I think the standards are really good. Biggest challenges are getting buy-in, and NCCHC came out of the American Medical Association in the 1970s. And this is back right after Estelle v. Gamble. That's a landmark case that y'all, need to brush up on. But it was in Texas, and the healthcare was so bad in Texas that it went all the way to the United States Supreme Court, and the U.S. Supreme Court found Texas to be unconstitutional for their healthcare. You had inmates caring for their other inmates, or medics, or unqualified healthcare people were providing healthcare. So Texas was under a federal receivership, the RUIZ for like 20 years. And now Texas is much better. California's been under receivership for 30 plus years, hundreds of millions of dollars. I'm not speaking negatively about California or their monitor. My personal opinion is I don't think that's an effective way to run a healthcare system. No disrespect, but I think attorneys should not be running healthcare systems. So anyway, so it's a challenge, but once you have the courts in your business, once you have attorneys in your business, it's really hard to get them out of your business. So by implementing standards, I'll say NCCHC, only 5 to 10% of facilities nationally are NCCHC accredited. The majority are ACA. So anyway, I think we have a lot of room to go. I'm gonna leave you with a really positive thing, very exciting. Look up the Harvard study. This was just published like 2 months ago, and I can send you all the link if you want. But a total separate group of researchers from Harvard came in and looked at jails and prisons that had NCCHC accreditation and found lower rates of morbidity and mortality and bad outcomes from facilities that were NCCHC accredited. So the proof's kind of in the pudding there. So.
And part of that really is in the support and implementation, right? That you have a community where you can learn from others. So we're hearing it's about standards. These are important to be adopted, but also the technical assistance, the staffing to actually implement it. So I think we have time for at least one more question. And this one is about like suicide watch. And so it sounds like this person might work in a hospital, but in the hospital, I've noticed a trend toward using remote visual monitoring rather than sitters or checks. Is there a move toward that in jails or prisons? And what kinds of policy and procedure changes are there being implemented related to suicide watch in jails and prisons?
I don't have a view into sort of a holistic look. This is, again, a problem of information. I know that has been something that some facilities have gone to because of staffing, and not always, as it doesn't always have good outcomes. And sometimes it's not preferred. It's not what they want to be doing. It's not what their policy says. But if you have one person staffing an area and they need to stay in the booth, then they are checking remotely. And so that's the main context I've seen it in. You also, I think it's worth remembering that a lot of facilities are quite old. We, again, don't want to spend money on jails and prisons. And so facilities that were built in the 50s, 60s, 70s, 80s may not have great monitoring. Dr. Penn referred to this as the physical plant problem. I know in our juvenile facility in Columbia, they've put in a bunch of cameras recently because there were large areas without visual surveillance and surveillance holes. And so I can't speak to it as a broader phenomenon, but I think sometimes the staffing has resulted in some of that, though a lot of facilities aren't really equipped for it because of outdated technology.
So I was just going to chime in that NCCHC has a standard, and they say that basically the use of video can supplement people, but it should not be used as an alternative to live humans watching. And I've been involved in some litigation cases where, not me personally, but where I was an expert witness, where it was videoed and you have the video of the individual killing themselves. So, unfortunately, when people are watching multiple monitors, and Lindsay Hayes is a big proponent of not using video monitors at all, except to supplement live people. So again, it boils down to, I think people think, oh, you have to strip them naked and put them in a cell, and that's not the case at all. You want to keep them safe and keep them from harming themselves, but you want to maintain their human dignity, be it a suicide smock or alternatively their clothing. And it's gradated based on their clinical presentation. But I think right now there's some talk, and I go to conferences and there'll be vendors that are trying to sell like pulse ox and blood pressure and heart rate, monitoring. And that's kind of cool. It sounds sexy and all, but we're not there yet. And so we do need to use technology. I think it'd be really cool if we had that technology, like core body temperature and that sort of thing, or heart rate. If the heart rate goes up super fast and then it slows down, that might be a risk. So I think we need to look at that stuff, but I think at this point, it's human beings and not just using video cameras at this point.
I would just add one piece as well, and this is my own bias. We talk about sort of the fancy technological solution, but sometimes it's the counterpoint to that is what is the simpler solution? And there's actually some evidence that rather than put people in segregation, if you double bunk individuals at risk, that can be protective. And it makes a lot of sense, right? Because there's another person in the room. And we're not asking the other person to necessarily prevent somebody from engaging in a suicidal behavior, but sometimes just their presence is enough that the person who's feeling suicidal is not going to act on that urge. So while there is a place for some of the, surveillance video technology, these pulse ox, all these cool things, I think even taking a step back and thinking about what's something that's simple and implementable, that could be a policy change as well, right? And that's going to be hard to break people of this movement towards segregation, but it might be actually that double bunking has a lot of value here, and I don't hear about it being used as much as people talk about it.
That'd be a great study, because I think I've been involved in a case where someone did have a cellmate and they had completed suicide. And the argument was, oh, you should have put him in the cell with a cellmate. He wouldn't have had a suicide. And I don't think there's literature to support that. So we need more research at the end of the day.
Well, this is such a good discussion. Thank you all. I want to just close out because we do have, I think, some delicious snacks and drinks back there. We're going to be hanging out for a while too. So those of you that are here in the room, I hope you can stick around if you have more questions. We're all open to it. We'll even split up so you can talk to us separately. But I'd like to close off and hear from each of our panelists on two things. So first, what's one thing that you're hopeful for the future in preventing suicide in correction settings? And also, what's one thing that you would like to see change the fastest? Maybe they're the same, but I think this will help sum up our conversation for those that have been here and carved out time. So thank you again. Where do we want to start?
One thing that I would love to see, I'll start with would love to see change is the idea that litigation first is a substitute for regulation, but also that corrections officials who don't want litigation and researchers who are pointing out flaws are working at cross purposes. I think I want the people to live and you also want the people to live. And even if we're going to make that about settlements and things, we have interest convergence there. And so I would like us to be able to see that we're all trying to pull in the same direction, even if I know as a lawyer, I am persona non grata most of the time, but really we are trying to pull in the same direction here. And the thing I think I am hopeful about is that we can treat people better. I think we can move away from some of these punitive things. And there are examples of jails and prisons that are doing it and doing it successfully. And I hope as I am not a very credible messenger for many corrections officials, but those who are working in those settings and making those changes are. And I hope their fellow law enforcement personnel will listen and see that there are better ways to do things.
So I'm going to cheat. I'm going to say three things. So one, I would like to get rid of malingering. I see a lot of people put malingering in their notes and then they have a complete suicide. And then the plaintiff's lawyer is like, doctor, were they malingering when they hung themselves? So malingering is kind of you can put, does not meet current DSM, diagnosis or what have you, or is feigning or is exaggerating symptoms. But putting the M word, once you put malingering, then the next time they see someone, be it for medical, for mental health, they're a faker, don't believe them, don't trust them. So I think malingering needs to go away. I think it's a useful clinical concept. And a lot of our individuals do location-seeking behavior or do medication-seeking behavior or disability-seeking behavior. I'm not judging them. I'm just saying that's a reality if you're behind bars. But I think malingering needs to go away, and not if staff will stop documenting that in their notes, that'd be really good. Two is secondary gain too. Contracting for safety. We published a study a while back, but that's a no-no. So people that say, promise me you won't kill yourself or sign here, there's zero evidence to prove that. So that's two. And sorry, the last thing, I think having our staff not just say, it's like a wish list, keep on suicide watch. What are you doing with this individual? What kind of counseling or therapy? Direct quotations. I really want to see my family, or these are kind of risk management best practices. I'm excited about the Super Bowl, or I hope I get my level, or I hope I get parole, or whatever. Anything that we show that we're engaging them, as opposed to no SI, no suicidal ideation, no HI, no homicidal ideation, no thought disorder. We need more freehand writing. I think we moved to electronic medical records. It's just check the boxes. So I think our staff need to up their game and document when they do a risk assessment and what kind of counseling or therapy they're doing with our patients. If they're just saying awaiting crisis management, well, what else are you doing for this individual? So I think we need to up our game. Mental health staff, just saying awaiting bed is not good enough. We need to do more.
So what gives me hope is that we're having this conversation and that we're increasing awareness of the problem. Because back to where we started, we have very little published data on the issue of suicides in jails and what happens pre and post incarceration. And I think bringing more attention to it and bringing the humanity to it is going to be very important, because this is a real public health issue. And the people that we're talking about, it's not sort of like those people behind bars. These are our family members, our friends, our community members. People come in and out of prisons and jails, but they're part of our communities. And we're talking about suicide prevention. And these are all really important things for us to be talking about. So that's what gives me hope. I think what I'd like to see change, and some of this is influenced by our research. So we are very interested in bringing tools and lessons learned for suicide prevention from health settings into this discussion. So things like, instead of contracting for safety, which even in healthcare systems, we don't recommend people do that anymore, bringing safety planning into jails. And hopefully soon we will publish our work to add to the literature to support that as a best practice. That's something we do already in emergency departments and inpatient settings. So we want to be able to say, look, this works too. You can do this in your setting. But similarly, in healthcare, what happens, and we just got new CMS codes to support this, is that we know from, you can look this up, the ED Safe study, that improving screening in EDs was not enough. You have to triage people to care. And that's where the impact was in that particular project. And similarly, we need to be doing that more for folks who are moving in and out of jails and prisons. So we can identify people at risk. We can do safety planning in jails or prisons. But what happens after? And we still have this very fractured system of care where we've got healthcare on one side and the justice system on the other side. And they still don't know how to really kind of carry people and support them across that transition. And what I would love to see is, and some of this might be legal in terms of like HIPAA laws and and who's paying for what. When we did our study of safety planning in jail, we brought community mental health clinicians into the jails because they were the ones that did the telephone follow-up with people when they got out of jail. And we were thinking this is a great idea because then we can support the efficacy or the effectiveness of this. We can bring people in. But when we got to implementation, everyone said, well, we can't bring community mental health workers into the jail. We have our own mental health staff. They should be doing the safety planning. But then when we said, well, who's going to do the phone follow-up when people leave jail, they scratched their head and said, oh, we can't do that because once they're out of jail, they're not on our caseload. And so it's a conundrum, but I feel that there's got to be a solution to that conundrum, and that we need to find that pathway that supports people at each step of the way.
And I think that pathway is being developed, and there was research even recently published through NCHATS that demonstrated that about 1 in 5 people who die by suicide in the US have spent a night in jail in the past year. And so there's a huge opportunity to connect those people to care, to change our systems, to change our culture, to treat this like a public health concern that it really is, and to make those positive impacts. So I'm encouraged because we thought that, we assumed that a few years ago, but now there's evidence to suggest it. And so more and more people are doing this work. And so if you're not working in this area, consider doing it. Whether you're a researcher, a public health expert, or a community member, get involved with your local suicide prevention coalition and encourage them to look at the criminal legal system in their area. Join NCHATs and get involved with other groups that are doing this work. Find out how you can get involved. It's an emerging field, and for all of the conversation, all of the challenges that we talked about, there is hope for the future to understand what we're up against better, to have more and more robust standards, but also change the culture so that we move from such a punitive, militaristic thing to treating people involved in the system like humans, because they are. So thank you all so much for your time today. Please give a round of applause to our panelists. And I think we have this room for like an hour now, right? Something like that. All right. Well, thank you so much. I hope you can stick around for some conversation afterward. Thank you all.